we might go about escalating medicines. So this is just your typical JIA patient. On the first screen, it's a 7-year-old comes in, referred from rheumatology, recently diagnosed ANA positive oligoarticular JIA. Again, first screening, 2020, pressures may be a little low. Anterior segment, other than 2+ cell and 1+ flare, no other complications, a little bit of rare kind of spillover vitreous cell, and everything else looks okay. So if I saw a patient like this in clinic, I'd call the rheumatologist because they just send them over and say, well, how bad are their joints? Like, how bad are we really looking here? And if they said, well, the joints aren't too bad, I'm going to try some naproxen, I might inject a joint, then that would affect what I would do. And so then we just kind of start down here with corticosteroids like everybody would. And as with the ACR recommendations, I do start with predacetate. I see people who jump right to Q2 hour Durezol, and I think you end up with so many other things going on when you start with that. That I think it's reasonable in these kids without really aggressive inflammation to start there. And then if they become quiet on predacetate, taper them and see what happens. And even though they have JIA, that doesn't mean they have to go to systemic medicines if they stay quiet. So then if they're not quiet, then I do escalate to difluprednate, go to Durezol, watch their pressures closely. You can see I use it even less. I'll use it twice a day, something reasonable like that. And then again, if we get them quiet, just taper them back down and monitor closely for reoccurrence. So this would be an ideal situation, and I have to say it doesn't happen very often. Our JI kids don't usually have one flare of uveitis and stay quiet, although it can happen. So 6 weeks goes on, and you're still using your steroids. You've tapered down a few times, it gets worse, you taper back up again, and it's time to make a decision. So at that point, that's a chronic anterior uveitis. And if their joints aren't that bad, nothing else is that bad, we move them up to, again, subcutaneous methotrexate. And it takes about 8 to 12 weeks for methotrexate to start working. So then you're back on your steroids, waiting for to see if methotrexate is going to do the trick. And towards the end of that 8 weeks, then I start to taper down the steroids if they're quiet, and see if we can get them off the topical corticosteroids. Okay. Other situation, you call and they're like, oh, Ashley's like, wow, joints are huge. Kids hobbling around, can barely walk, what should we do? And so at that point, we'd go to steroids, but we'd start methotrexate right there, knowing that they're gonna need it for their joints, knowing that delaying methotrexate, knowing that we're probably gonna start it anyways, is making them for another 3 months of steroids that we wouldn't have to wait for. So we get everything going right away, and that's not unusual that we do that. Or that the rheumatologist has even started that in the clinic before they've come to see us. So we'd go right in with that if we had significant joints and uveitis at the same time. And then what happens 3 months, we get that 3 months down the road, they've been on methotrexate for 8 to 12 weeks, and they're not quiet, and they can't come off of steroids. And so then we move up the ladder again, and then we go to TNF inhibitors, just as Dr. Cooper talked about. As recommended in the ACR guidelines, and we give patients a choice. And we say the bad part about adalimumab, Humira, is that you're going to have to do a shot at home every 2 weeks, and we dose it based on weight. And if they say, oh my gosh, we can't get these methotrexate shots done, those are so hard, we can't add another shot, we don't want to do it, then we say, Remicade and infliximab is also an option. And if you want to do that, then great. We don't know which one's better, but we think that they're both good options for that next step up the ladder. I have to say most of our patients, just based on convenience, choose adalimumab first. Okay, so a little different case, as we've alluded to before. This is somebody who presents with complications already. So a 12-year-old comes in with bilateral red eyes. Ginny said, so they never present at the same time, and it's true. They'll tell you one eye was red 4 weeks ago, and then the other eye was red. I've been treated for conjunctivitis, and now I've got these 2 painful red eyes. They often have photophobia. Some of them have headache, and that's going to go along with something else I'm going to talk about, and just kind of that vague eye pain. They turn out to be HLA-B27 positive, which isn't a surprise. Vision's down a little bit in both eyes, pressure's low. You see 2 post-conjunctival injection, a few KP, about the same cell and flare as the other child, but you're getting some early synechia. And then when you look in the back of the eye, you've got a little bit of cell, but you've also got 2+ optic nerve head edema, so you've got some papillitis. So the OCT, I don't think you can see the numbers, but the right eye, as far as RNFL thickness, 163, left by 341. So we see some pretty edematous nerves associated with these uveitis kids. And so in this case, predacetate, and I'm going to do it because it's not going to get to the back of the eye. So in that case, I consider starting with a trial of difluprednate. So try the Durezol just because it's stronger and it gets to the back and it can lay down a nerve in some situations. Since we started, to kind of call it the Durezol era, since we started using it in kids, I rarely have to go to oral steroids in kids with uveitis, which I think if we can keep kids off of oral steroids, I think that's a real benefit, and I think it's worth trying. If that doesn't work, I will consider oral steroids and also consider a Sertinon's injection at this point to try to bridge us over. And then this is probably, you'll hear some difference, even I'm sure people in the room, people on the panel, on whether we would go to methotrexate first or whether we just skip methotrexate and go straight to TNF inhibitors because this person's having ocular complications and potential for long-term vision loss. We'd like to be able to get them off steroids as quickly as possible. So the point, and I've left some time for conversation here too, is don't be afraid to climb that ladder. We have a paper we presented at APOS this year, and hopefully will be published at some point here, that in our total population, and it was about 70 kids with uveitis, all comers, so anterior, posterior, JIA, and idiopathic, that about 40% of them responded to methotrexate alone. And so we had 60% of our kids on systemic medicines needed TNF inhibitors and often escalated doses of TNF inhibitors. But in the end, all of them were quiet, off of steroids. So you can get there, and sometimes I think that's where, Ashley and her partners come in, is that's kind of scary to rheumatologists when we just keep pushing it and say, no, we need more. And I think their guidelines, you could send them back to their new guidelines. I don't know if you think most rheumatologists know those or not, but to say, you know what, there's good literature out there and there's good guidelines to say, keep going until we get this disease under control. So happy to have you guys talk a little bit too.
I find in my population that I even if I would want to prescribe Durezol, not many patients can get it, not a lot of insurance covers it, so
And in Kansas City, where I am, I don't think I've ever had anybody who couldn't get Durezol. So it's just a difference in where you are and what you have access to. And I know that Ginny uses a lot of FML, and I can't get that. So it's very location dependent and place dependent. Question?
How often are you following your patients when you start
So I won't go under every 2 weeks for a pressure check. I mean, it can be, there's a Deb Goldstein article that says that kids on Durezol can have amazing pressure rises and very quickly, and I've seen it and I expect it and I tell the patients to expect it. I think it's worth the trade-off to have those frequent exams and just to treat the pressure if it happens, but you gotta know that it's a possibility.
Even as a dealer?
Mm-hmm. Yeah.
I think it's over 10 years ago, I was treating a teenager that was refusing to do any of the biologics, and so I feel like you can sell sepsis, but I don't remember if that was helpful. What's the modern take on that now? Is that, what do you do above that, ACE-type and things like that?
So I think if you have a patient who's absolutely refusing any biologic therapy, options that would be reasonable to consider would be Celsep or myclophenolate or potentially cyclosporin. We've had good success with that in some of our patients, but that requires a lot of monitoring. So sometimes I think patients are scared of biologics, but we just have a lot of open discussions with them about what we really perceive the relative risks of these medications to be. And personally, if I were in the boat of having to decide, am I going to take Remicade or am I going to take cyclosporin and need to have levels monitored and worry about kidney function and blood pressures and all those things, I would rather be on Remicade infusion. So I think, at the end of the day, you have lots of options, but discussing with the family, we have a lot more evidence for using TNF inhibitors at this point, and just relative toxicity is helpful.
Celsep doesn't work for the joints. If it's someone who has JIA and their arthritis is bad too, it doesn't work for the joints.
Yep.
Going back to the previous presentation with the APOS forms, requiring the ANA in order to determine frequency of follow-up? I mean, that's still the current recommendation, is it not? So in our area, whenever the pediatric rheumatologists see the patient first, they don't ever order an ANA.
So
And
for a
it's-
patient with JIA?
Yeah.
Oh, where do you live? Sorry, not to put you on the spot, but.
Yeah, I mean, it's really sort of bizarre, and I end up having to, send them back to get the ANA. And they draw blood, but they don't draw an ANA.
Yeah.
And they send them to me with that diagnosis. So I'm just wondering, is there something going on in the rheumatology world?
No, I would have no idea how to recommend eye screening in a JIA patient without an ANA.
Okay.
In the reverse, however, if you were to diagnose uveitis, chronic anterior uveitis, and you're looking for an underlying cause, that's what we see on the flip side is, patients are referred to us for workup for what's causing their chronic uveitis. I'm not sure that the ANA really has much value in that direction.
Right.
I'd rather see them do a joint exam to look for arthritis than have that